Thank you so much, Tamara, for inviting me to present today. And what I thought I'd do is separate this talk about gene therapy into two sections. One is the first is the basics aspects of gene therapy. And the second is to really think about what the rocket gene therapy for PKD looks like. And I hope that you'll have questions at the end. I have disclosures. My first disclosure is for Vertex and a second for Bluebird Bio. I don't have relationships with Rocket other than being the PI for the site. So PKD, as Dr. Grace has already talked about, is a rare genetic autosomal recessive disorder that results in severe hemolytic anemia. It is the second most common cause of hemolytic anemia, and it is caused by a defect in a gene known as PKLR. And most of you know all of this information. What is pyruvate kinase? It's an enzyme that helps turn sugar, which is glucose, into energy in a process called glycolysis. Red blood cells rely on this process for energy. And therefore, if you don't have this process ongoing, PKD will result in a deficiency and premature destruction of the red blood cells, or hemolysis. Most red blood cells will last about 120 days. However, with pyruvate kinase, these cells do not last very long. As you know, and most of you know, there are many complications of PKD, which includes extramedullary hematopoiesis, splenomegaly, leg ulcers, growth retardation, jaundice, but more severe complications that are also found are organ dysfunctions, including pulmonary hypertension, thrombosis, and heart failure. And this is the slide of what these cells look like. Normal red blood cells will have a normal round red coating, and whereas PKD cells are broken up, and this is what they look like. So what is gene therapy? Gene therapy is a technique that modifies a person's genes to treat or cure a disease. In order to insert that gene into a cell, we use something called a vehicle or a vector. And vectors are things we make in the laboratory. They're engineered to deliver a necessary gene for treating the disease. Gene therapies can work by several mechanisms. One, it can replace a disease-causing gene with a healthy copy of a gene. It can inactivate a disease-causing gene that is not functioning properly, or it can introduce a new or modified gene into the body to help treat a disease. And this is what's happening in PKD. So a lentiviral vector is a retrovirus. And what that means, has a single-stranded RNA genome. And don't worry, I'm not going to make this too scientific. But just for you guys to know, lentiviruses can carry large genes as well as small genes. And this has been a problem for some of the other diseases by not using this. And lentiviruses can infect cells whether or not they're dividing. Every cell either sleeps in our body or is growing rapidly. If cells are growing rapidly, it will take up a vector very quickly. If a cell is sleeping, it won't do that. And therefore, this type of virus, all cells can take this particular vector up. Therefore, you can get a larger number of genes into the cells. The drawbacks of using this type of vector, though, is its origin is from an HIV virus. And I want everybody to know with the lentiviral vector, we've treated more than 500 patients worldwide with this type of a vector, and nobody has developed HIV. However, it is something we put in all of our consent forms that people know it comes from an HIV, and that we cut the HIV virus so it can't grow, and therefore it will still be in our body. We may show up as being HIV positive, but a screening test, that's from the screening test, and then from the actual final confirmatory diagnosis, you're not going to be HIV positive. But it is something we let all the families know that this is coming from an HIV virus, because obviously that's concerning. Gene therapy has 4 distinct phases, and this is how I describe it for families that I'm talking to about gene therapy. The first set is called the screening phase, and in the screening phase, it's about 1 to 2 weeks. And what we do is we talk to the families, make sure their organ function is good. We make sure that they actually have the gene that we're trying to fix. And we make sure that they are really eligible to undergo the therapy. Once that screening is complete and everything is ready, then we basically bring the patient back for something called the stem cell collection and transduction. And in this phase, it takes about a week in the hospital. And what we do is we give a medicine called GCSF, which is a little shot underneath the skin that makes your white cells grow. In addition, we also we'll give a medicine called plerixafor, which is also another shot underneath the skin that causes the stem cells to come out into the blood. And what happens is patients then are connected to a machine. And this process of GCSF and plerixafor lasts about 5 days or so. And then these patients are put under a machine, and we put 2 IVs into each arm. One IV, we pull the blood out, it goes through a machine, we keep the stem cells, and we give you back your red blood cells and your platelets. After the procedure is complete, then you get to go home. The patients during this process are in the hospital mostly because these medicines are given in the middle of the night, this GCSF and plerixafor. And therefore, it's hard for us to usually have somebody in a clinic that's available to do something like that early in the morning. After the patients go home, these cells that we've collected go to the manufacturing facility. And that process of putting the vector that we just talked about into the stem cells takes about 6 weeks to 8 weeks, depending, okay? Once we have the cells shipped back to the site that's going to be doing the transplant, the patient will then come back to the institution, and the patient will undergo some tests just to make sure they're still healthy and that there's nothing going on. Then they're admitted to the hospital, and then they'll get a chemotherapy agent called busulfan for 4 days. And although I say this is a generic for gene therapy, almost all of the studies I participate use only busulfan, but I have a few studies that, or a few trials that they need more than busulfan. Just for you to know, when we talk about the PKD gene therapy, it is only busulfan that patients get. Some people get busulfan once a day. Some people get it every 6 hours in a smaller dose, but it's essentially the same full dose of busulfan. After the patient gets the chemotherapy, they're kept in the hospital until the new stem cells start to grow. And once they start to grow, the physician that sees you will decide when you're ready to leave the hospital. Most often people will stay locally to the institution just to make sure they're healthy. And the physician will then decide when they can actually go home, right? All of the gene therapy trials need to be followed for many years after transplantation, and this is an FDA requirement. So although most studies will just follow the patients for the first 2 years, afterwards, patients will oftentimes be enrolled onto a late effect study so that they're managed and looked at least once a year to make sure that there's no complications from regarding the gene. So, what is the goal of lentiviral gene therapy for PKD? It is to insert a functional PKLR gene into those patients with PKD into the patient's stem cells. And what it does is then it'll normalize the red blood cell function as well as the lifespan. So we talked about collecting the stem cells, selecting out just the stem cells, which is what's called a CD34 positive cell, going to the laboratory to put in the PKLR gene. Once that's done, the patients are then brought back to the institution that's doing the transplant. They receive the chemotherapy, and then we infuse the cells that have been sent back. And then we wait until the cells start to grow. Finally, after engraftment, what happens is these gene-corrected red stem cells will then start making normal red blood cells. And this is what a normal red blood cell can look like. And you remember the previous picture, there is a shaggy edge of all the red blood cells. And in this particular situation, now they're normal and healthy and come back to normal. So now the next set of slides is going to be slides that I've received from Rocket, and I want to talk about the PKD trial itself. So as we talked about, we basically just discussed how we collect the stem cells, we give busulfan chemotherapy, infuse the stem cells. These cells that had been previously done, this is the CD34 stem cell. This is the vector that contains the correct gene in it. And then when these stem cells start to grow, they incorporate the vector with the gene inside of it. And that's done at the manufacturing facility. sent back here, and these are what your normal red blood cells will look like. So for PKD, as we talked about, we get GCSF and plerixafor. So GCSF is the top. Patients get that for 4 days. And plerixafor is given the night before the stem cells are collected. And oftentimes we'll collect the stem cells for 2 and possibly 3 days. Once we collect enough stem cells, that's when we know we can stop collecting the cells. Okay. What are the side effects of busulfan? There's many short-term side effects, and then there's long-term side effects. And the short-term side effects are mostly resolved. So these include things like nausea and vomiting. And we have very good antiemetic therapy. So patients get an antiemetic is an anti-vomiting medicine. So patients will get that as a pre-medication and throughout the time they receive busulfan. There will be hair loss. Some people will lose all their hair. Other people will have thinned hair. And hair usually starts to grow back about 2 to 3 months after the transplant. Now, I will warn you, some patients are older. And if you're older, there are patients that are having hair loss that because of their age. And sometimes that hair will remain thin or remain lost because of the age of the patient and what condition they came in. Okay. Most of my younger children, though, have a normal head of hair after a few months. There's a process that's called VOD, or liver inflammation. And that can happen with patients with PKD for several reasons. People with PKD oftentimes have iron that's developed in their liver from all the repeated transfusion. Every time you get a blood transfusion, some iron will end up in your liver, but it can also go into your pancreas or potentially around your heart. All the patients that go on this particular type of a trial are assessed to see how much iron overload they have. And many of you in the audience probably are on an iron chelator to try to decrease the amount of iron that's in your body. So when your liver has so much iron in it, you're at risk of developing liver inflammation. Therefore, all of our patients will get some form of prophylaxis to try to prevent this complication. This is a very known complication of patients with transplantation, and most people will have only a mild form of this. Some people can have a severe form, and that's the job of the transplanters to actually think carefully about how much liver inflammation there might be and how much prophylaxis needs to be given. Some people will get mouth sores. Mouth sores will happen in the mouth or anywhere down the GI tract. And this tends to happen because chemotherapy kills cells that are growing quickly. On the other hand, when the cells start to come back, they will all go to the areas that have been damaged by the chemotherapy and start to heal it. For the first couple of weeks, some people may not be able to eat and drink well because of the mouth sores, and that's our job to find a way to make sure everybody gets good nutrition during this. Some people will need pain medications, and some people will need IV hydration. And the last thing is it decreases the blood counts. So people always say, why do I need to get any chemotherapy? I don't have cancer. And that's a really good question. If I just give the modified stem cells back into your body, there's no selective advantage for them to grow because you're already making red blood cells, white blood cells, and platelets. You're making a whole complement of cells, and the bone marrow then won't have any space in it to grow. If I get rid of all the cells you're currently making and give you back the new modified stem cells, if the bone marrow is empty, then the modified stem cells have a place to go into your bone marrow and have a chance of growing. All of these short-term side effects will improve after the stem cells start to grow. There are some long-term side effects that we want to talk about. First, busulfan can affect the lungs long-term. It's a very rare occurrence. And oftentimes the patients we're talking about who've received busulfan are patients who have had cancer in the past and therefore have had multiple rounds of chemotherapy before they ever came to transplant. I have not had many patients get pulmonary toxicities in the late effects clinics. However, it's something we continue to monitor for closely. There is a risk of any chemotherapy causing secondary cancers, although this is quite rare. And most of the patients that develop secondary cancers are patients who have had cancer in the first place. Many of you have reached out to me and asked me about fertility because this is one of the major issues that occurs, especially for children. Many children, after they receive busulfan, will not be able to have children, but not all kids. We do know that we have had some patients who have received busulfan who have been able to have a kid. And some other patients, though, are not old enough to know whether they can have kids, or old enough to, they can all potentially have kids. They shouldn't necessarily all have kids or try to have kids. And so we always think through, okay, if I have kids in their early 20s, they're not able, they don't have a kid, but is it because they're not trying to have a kid, or they don't want a kid, or any of those kinds of factors? In the PKD gene therapy trial, many will have fertility preservation prior to undergoing gene therapy. And this is oftentimes covered by the trial. But most insurance companies, if you have a life-threatening illness such as this, many insurance companies will also cover fertility preservation as well. This is something to really discuss carefully with your physician if you decide to embark on some kind of therapy such as this. And as I said, although we collect the sperm or the eggs for patients who are undergoing busulfan, I can say that these trials are very early, and therefore most of the patients have not had a pregnancy afterwards, because most of these trials are within the first few years of life. And as time goes on, there will be potentially more information regarding that. But as I said, most patients won't. In our two patients that have been tried on this particular trial, both of them were older. One had fertility preservation, but is not in a committed relationship and therefore is not trying to have a child. And the other one already had kids and therefore wasn't interested in having any more. So we don't have a really good answer because of these two patients being just older. As we start enrolling pediatric patients on this trial, then we may be able to have some data for what happens with fertility long-term. Now, as many of you have probably heard in the news, there is a risk of insertional mutagenesis with the lentiviral gene therapy. And I want to specifically talk about these particular patients so you understand the difference between the leukemia that occurred in 3 patients who had a different disease compared to patients that have not had the same disease. Bluebird Bio has a study for patients with a disease called adrenoleukodystrophy. Adrenoleukodystrophy is a disorder in which the neurological function it's an inherited disease with a gene that causes neurological dysfunction and death if not treated, and if the patients have lesions in their brain. 67 patients have been on this particular trial over the last 10 years, and 3 patients have developed leukemia and required a second transplant. 1 patient developed this problem at 14 months, another at 22 months, and another at 7 years post-transplantation. So, as I said before, ALD is a disease that affects the nerves, essentially, the axons of the nerve. And if you need to get this gene to every place that there is a nerve, which is essentially all over your body. And therefore, in order to get it into all these places, including your brain, which oftentimes gets spared, there's something that's called a promoter, and a promoter that helps this gene get to every part of the body. This promoter is known as MND, and it was used, as I said, because we needed to get it to every nervous tissue. This promoter caused this gene to insert in a specific area of the DNA that can cause leukemia. In patients with PKD, we did not use a strong promoter because we only needed to get the gene into the red blood cells, because that's the only place that there's a problem. And most of the patients on lentiviral gene therapy trials across the country, and as I said, there's almost 500 patients across the world that have been treated with lentivirus. Most of them did not need the strong promoter, and therefore have not developed leukemia. This is the only study that has developed leukemia of all of the patients that have developed lentiviral. Obviously, we all continue to monitor every single patient very, very closely, and will continue to do so through and down the road. But these are the only ones that we directly know that the gene inserted into the DNA and caused the leukemia. There is one patient also on a Bluebird trial who had sickle cell anemia who developed leukemia 7 years after the transplant. The gentleman did not have any insertional mutagenesis, which means that when they looked at the DNA, we did not find the gene in the DNA in an area that can cause leukemia. So the leukemia did not occur because of the gene insertion. At the time of transplant, the man was 36 years of age and 45 at the time he developed leukemia. So he was older. And the only thing we could say was maybe it was related to busulfan. I will point out that we have had many patients over the last 30, 40 years who received busulfan, and busulfan was not known to cause leukemia. So why do we say this one was caused to leukemia? That this busulfan caused the leukemia is because we don't have any other reason to say why he got leukemia. However, as many of you will also know, people with sickle cell anemia are at higher risk of developing cancer, especially leukemia. And as we get older, unfortunately, and I'm in the older range, we're all at risk of developing cancers as we get older. So we don't know specifically that the busulfan caused the leukemias per se, but we do know that there is always a risk, and that's why patients will continue to be monitored for many years after transplantation. So let's talk about the rocket gene therapy specifically and the outcomes that we've seen. So as I said before, this trial was developed in 2 sites, one in Spain and one with me at Stanford in Palo Alto. And what the purpose of this trial was to really look at the safety and the toxicity of the gene therapy product, which is called RPL301. Okay. The patients were divided into different cohorts. So the first cohort was the adult cohort, which is greater than 18 and less than 50 years of age. And those 2 patients have been treated successfully, and we'll present those results. The pediatric cohort will have 2 patients. 2 patients have been enrolled. They have not been infused yet, so I don't have any data I'll present on those particular patients. All the patients had to have severe transfusion-dependent anemia, good organ function, which is heart, lungs, kidneys, and liver, and they had to have a splenectomy prior to coming into the transplantation to be eligible. They could not have any other known cause of hemolysis, and they could not have had thrombotic events in the prior 12 months. They could have severe iron overload, but they could not have fibrosis or cirrhosis in their liver in order to be eligible for this particular trial. Okay. So let's talk about patient number 1. Patient number 1 was a 36-year-old female who'd had an average hemoglobin of 7.4 in the 2 years prior to joining the trial. She'd had over 14 transfusions in the previous 2 years. Her bilirubin was 13.4 at the start of the trial, and she had had several hospitalizations for hemolytic crisis. And as you can see, she had several different infections along the way prior to enrolling onto the trial. After the infusion, and you can see here before the transplantation, day 0 is the day of transplant. You can see all these little openings where she had blood transfusions or not had low hemoglobin but no blood transfusion. Following the transplantation, she has developed a normal hemoglobin, and this is from 1 year to 2 years even. She has stayed consistently in a normal range for a female. Her bilirubin has decreased from 13.4 at the beginning of transplantation to 1.4 after few months, and has consistently remained in the low normal range. She's had a consistently low reticulocyte count, which means she's not hemolyzing a lot. And the last thing we would see is that we're able to see the gene still in the blood at almost 2 years post-transplantation. And I think these studies, this data cutoff was in April of 2022. We have follow-up data to the 2-year 24 mark. Patient number 2 was a 47-year-old male who was also diagnosed in infancy and had a splenectomy. He had several infections, including hepatitis C, which was successfully treated. But more recently, he's had a foot ulcer requiring a skin graft. He elected not to receive so many transfusions because of the iron overload. And therefore, although his hemoglobin was around 7, he only got about 5 transfusions, but he was made eligible because he was so low, and occasionally he would only get transfusions when he hit a hemoglobin of 5 to 6, which is quite low. His bilirubin at the start of the infusion at the transplant was 7.4. And for this gentleman, his hemoglobin improved very quickly after the infusion and has consistently remained in the normal level for an adult patient. His bilirubin was, as I said, 7.4 in the beginning, and he had stayed consistently in the not less than 1 range since transplantation. His reticulocyte count has normalized, and so he's not breaking down the red blood cells. And as you can see, the amount of gene still remains present in the blood up to 12 months. We're still waiting for the 18-month evaluation and the 24-month evaluation because I think they batched the blood. So stem cells were successfully collected from both patients, and the gene therapy product was successfully manufactured in both of these patients. Both patients were infused with the product without any infusion-related effects. And the side effects from the busulfan were really expected, temporary, and managed with supportive care medications. None of the patients developed any of the severe complications that we had talked about regarding busulfan. In conclusion, gene therapy offers a curative approach to the treatment of many diseases, including severe combined immune deficiency, adrenoleukodystrophy, and hemoglobinopathies. Many of the gene therapies are now being approved by the FDA, and it's expected that several more will be coming soon. And the reason why I bring that up is patients who the ALD trial has now been approved by the FDA. There is a sickle cell and a thalassemia trial, that has been approved by the FDA, and it's expected the sickle cell trial product will be approved by the FDA by the end of the year or soon thereafter. There are many other companies with different other approaches for different diseases, and many of them are looking to have their products also approved in the coming year. So this is a very moving target. Once these are approved, then it's a discussion with insurance companies to pay for the product, and that is an ongoing discussion. The concerns regarding insertional mutagenesis is for all patients, and the FDA will still require us to monitor every patient for at least 15 years after the transplantation. And this requires you just to have blood drawn. So many of the patients, are not expected always to come back to their primary institution 15 years down the road, but we will make attempts to make sure blood is drawn wherever the patient lives and to make sure we assess that for any kind of complications. And with that, I will close and leave it open for any questions, either through the chat, or if you have any questions specifically related to your child, please feel free to reach out to me. Here's my email and we can discuss that. Thank you.